We always hear about diabetes management, and it's almost always about tighter control, right? Get those numbers down.
That's definitely the standard message. Absolutely. Lower is better.
But what if maybe that's not the entire picture, especially as people get older?
Yeah, it makes you sort of pause and reconsider some really fundamental ideas, doesn't it?
Totally. I actually stumbled across this New York Times article recently, and it really made me think.
Oh, yeah.
Yeah, the headline was pretty bold, something like, "Older people may not need to watch blood sugar so closely."
Wow. Okay. That headline alone probably raises a lot of eyebrows and maybe some concerns for people actually living with it.
Exactly my thought. If you're managing diabetes yourself, or maybe you're caring for an older parent or relative with it, hearing that kind of makes you go, wait, what?
What's the thinking there? What are the potential downsides or trade-offs?
Right. It pushes you to think beyond just the A1C number and look at the whole person, the quality of life for older adults.
So let's dig into that. What's the core argument the article is actually putting forward?
Okay, so the main idea basically is that for older folks, pushing for really, really tight blood sugar control might not actually provide the same level of benefit as it does for younger people.
Okay, that makes a certain amount of sense just on the surface. Our bodies change, priorities change. But what's the main reason why? What's driving that perspective?
Well, the article puts a huge emphasis on the risk of hypoglycemia, low blood sugar.
Oh, okay. Hypos.
Yeah, and specifically, it argues that the risk of those hypos is significantly higher in older adults, and the consequences can be much more severe.
Right, hypos are never good, but what specific dangers is the article pointing to for older individuals?
It really highlights the increased danger of falls. A sudden drop in blood sugar can cause dizziness, confusion, leading to falls.
And falls in older adults can be devastating. Broken hips, head injuries.
Exactly. Serious injuries. And it also mentioned potential cognitive issues linked to severe or frequent hypos.
Those are definitely major concerns. So the thinking is maybe avoiding those immediate, potentially catastrophic events is more critical than getting that A1C down those last few points.
That seems to be the core logic. They even put a number on it, defining hypoglycemia in this context as blood glucose below 70 milligrams per deciliter.
Okay, so 70 milli-GDL. That gives a clear benchmark they're working with.
Yeah. Now, the article also states pretty clearly that these hypo episodes just happen more often in older adults. Did it say why?
It mentions that increased frequency as a really key part of the argument, but it doesn't actually dive too deep into the physiology of why it happens more often. It's presented more as like an observed fact, a known risk factor in this population.
Interesting. That feels like a gap, doesn't it? Something that needs more looking into. But okay, moving on. There was this really striking example in the article.
Oh, yeah?
Yeah. Described doctors actually advising an elderly woman who had always kept her A1C really low, like under 7%, to let it drift up.
Wow. Okay, that is a shift. Imagine being praised for years for tight control and then being told, actually, let it go up a bit.
Right. It must feel completely backwards. For someone who's worked so hard to keep those numbers down, hearing that advice, it's got to be jarring.
So what's the rationale there? Why deliberately aim higher?
The underlying philosophy, as the article presents it, seems to be this kind of mantra. Don't worry so much about the highs, focus really hard on preventing the lows. Specifically for older adults.
That is such a different focus. Usually it's all about avoiding the complications of high blood sugar, right? The long-term damage.
Exactly. This really flips the script, prioritizing avoiding the immediate, possibly severe fallout from a hypo over the longer-term risks of slightly higher glucose.
So is this idea totally new? Or has this thinking been around?
Well, the article does mention that this perspective isn't entirely novel. It points out that some doctors have, kind of quietly perhaps, leaned this way historically.
So maybe allowing slightly higher levels in older patients to specifically dodge those hypos has been practiced before.
Seems like it. Maybe it's just getting more attention now. And the article backs this up by mentioning recommendations from professional groups.
Right. I think it mentioned the American Geriatric Society.
Yes, exactly. And their recommendation, apparently for over a decade now, has been an A1C target of 7.5% to 8% for most older adults.
Okay, 7.5 to 8%. That's definitely higher than the under 7% or even under 6.5% targets you often hear about for the general diabetic population.
Significantly higher. And it even mentioned that for older adults with multiple other serious health conditions, the target might go up to 9%.
9%. Wow, that sounds really high compared to the usual goals.
It does. But I guess it really highlights this different calculation of risk versus benefit when managing diabetes in, advanced age or with complex health profiles.
And there was a specific term the article used for this strategy, wasn't there? About backing off on treatment.
Yeah, they called it de-intensification.
De-intensification.
Which basically refers to the idea of potentially scaling back on the medications, reducing doses, maybe stopping a drug altogether.
Okay, that makes sense if the primary goal is reducing the risk of medication-induced hypoglycemia.
Exactly. And that brings us to another key point. The article was very clear that this increased risk of hypos isn't tied to all diabetes treatments equally.
Right. It singled out specific ones.
Yes. It mainly pointed the finger at insulin, which makes sense, and also a specific class of older oral medications, the sulfonylureas.
Ah, the sulfonylureas. Like glyburide, glipizide, glympyride. Those
Those are the examples they gave, yeah.
Yeah.
Known for being pretty potent glucose lowers.
And how do they work? Did the article explain why they carry a higher hypo risk?
It used a really good analogy, actually. It said they work kind of like squeezing a wet washcloth really hard to get every last drop of water out.
Okay. Meaning?
Meaning they basically force the pancreas to release more insulin, whether your blood sugar is high or not. You just keep squeezing out insulin.
Ah, so they stimulate insulin release regardless of the actual glucose level.
That's the idea.
Yeah.
Which means they can easily push blood sugar too low if you haven't eaten enough or if you exercise more or, if the dose is just a bit too high.
Got it. That's a very clear picture. They lack that sort of glucose-dependent action that some newer drugs have.
Right. But, while the article focused so much on medications and hyporisk, there felt like a huge piece missing from the discussion. Something really fundamental.
Let me guess. Diet.
Exactly. The article barely mentioned the role of what you eat in managing blood sugar levels. It was almost entirely focused on medication adjustments.
That's a really significant omission, isn't it? I mean, for so many people with type 2 diabetes especially, diet is absolutely central.
It's foundational. It felt strange to read this whole argument about adjusting A1C targets and de-intensifying meds without really talking about the impact of food choices.
Because dietary changes, particularly things like lowering carbohydrate intake, can have a massive impact on blood glucose, a huge impact.
Right. And if you can achieve better, more stable blood sugar through diet,
then you might need less medication or lower doses of those medications, like insulin or sulfonylureas, that carry the highest hypo risk.
Precisely. It seems like a critical part of the equation that wasn't really explored. If you reduce the need for those high-risk meds through diet, you inherently reduce the risk of hypos.
It offers a different path, potentially, a way to maybe get good control without dramatically increasing the danger of lows. It's a more holistic approach, perhaps.
Yeah, holistic is a good word. Now, the article did stress monitoring glucose levels, especially if treatments change. That's still vital, right? Even with looser targets.
Oh, absolutely critical. Whether you're changing meds or making significant dietary changes, you have to monitor frequently.
Can't fly blind.
No way. You need that data to see how your body is responding, to make informed adjustments with your doctor, and to catch potential highs or lows before they become serious problems. Communication with the healthcare team is key there.
Okay, good. So monitoring is still paramount. Now, another point the article brought up was about life expectancy.
Ah, the idea that the long-term benefits of tight control might take decades to show up, and older individuals might not see those benefits realized.
Exactly that. What's the counter argument or a different perspective on that?
Well, even if the time frame for preventing some classic long-term complications, like, say, kidney disease progression, might be less relevant for someone with a shorter expected lifespan, maintaining healthier blood sugar levels through diet now can still dramatically improve their current quality of life.
That's a huge point. Feeling better day to day. More energy, less fatigue, clearer thinking. That matters immensely at any age.
Absolutely. And who's to say better control, even later in life, can't still slow down the progression of existing complications or reduce the risk of things like infections or poor wound healing, which are definitely relevant.
Good point. So it's not just about preventing something 20 years down the road. It's about better health and function today.
Exactly. The article sort of frames it as this stark choice. Accept the risks of long-term high blood sugar complications, or accept the immediate risks of hypoglycemia from intensive treatment.
Yeah, like it's an either-or situation.
But is that really the only choice on the table?
That's the question, isn't it? Because if diet is brought more prominently into the picture,
then maybe it's possible to achieve reasonably good blood sugar control, improving current quality of life and reducing some risks, while also significantly minimizing the reliance on medications that cause dangerous lows. It suggests the dichotomy might be, well, maybe a false one, or at least an incomplete one.
Okay, so wrapping up this deep dive then, we've looked at this NYT article suggesting less stringent control for older adults to avoid hypos.
Focusing on that risk of lows, potentially allowing higher A1Cs, de-intensifying meds like insulin and sulfonylureas.
And we've contrasted that with the perspective that really emphasizes the power of diet.
Right, the idea that dietary changes, like low-carb approaches, could potentially offer a way to get good control and minimize hypo risk by reducing medication needs.
So for you, listening in, what's the main takeaway here when you think about diabetes management, especially for older people you might know or care for?
I think the absolute key is understanding the individual context. It's not one size fits all. What medications is the person taking? Are they ones with a high risk of hypos?
And crucially,
What role is diet playing? Has a dietary approach, one that could potentially stabilize blood sugar and reduce medication dependency, really been explored or optimized?
it leads to that final thought, doesn't it? Is this push towards prioritizing hypoprevention,
Yeah.
even if it means letting blood sugar run higher, the best or only compromise for older adults?
Or is there a more integrated, perhaps more empowering approach centered around dietary strategies that we should be giving much more serious consideration to? One that aims for the best of both worlds.
Definitely something to think about. Really appreciate you breaking this down.
My pleasure. It's a complex issue, and the key, as always, is personalized care, informed discussion with doctors, and considering all the available tools, including diet.